Greetings, and welcome to the Evidence in Motion Concussion Management Certification Information Session. My name is Dr. Jessica Schwartz, and I'll be your program director for the next year. I'm an orthopedic residency-trained doctor of physical therapy, a practicing clinician, and one of the national spokeswomen for the American Physical Therapy Association. Most importantly, I'm a post-concussive syndrome survivor who underwent 10 plus hours of rehabilitative therapy for over a year. This quote has stuck with me through the latter portion of my career since my injury. To feel with stirs us to act for. I challenge you to think outside of your clinical comfort zone during this presentation. I've dedicated this program to the hundreds of thousands, if not millions, of people worldwide suffering from the persistent symptoms of post-concussive syndrome. The key questions I'll cover over the next half hour are what this program is intended to be, the how it will be delivered, why I chose Evidence in Motion as the home for this program, why there is a need due to educational gaps for a concussion education program, why the inspiration, and when this will happen. So let's go. Here's the what. The Evidence in Motion Concussion Certificate Program is committed to educating the post-professional multidisciplinary clinician of today in concussion identification, treatment, and management by fostering a rehabilitative team approach. This 12-month program provides the latest clinical conversations, evidence-based guidelines, and consensus statements while integrating real-world experiences from patients, providers, and caregivers who have navigated the complex healthcare network of today. Content delivery is both interactive and dynamic, exposing the student to some of the most influential clinicians in the concussion community, coupled with the unique learning experience of provider-to-provider, patient-to-provider, and caregiver-to-provider storytelling. I hope to foster advancement in your clinical competency as my main goal as program director, while bridging these gaps intra, inter, and across disciplines. By fostering a rehabilitative team approach, the Evidence in Motion Concussion Certification hopes to facilitate collective competence across the healthcare continuum in order to better triage, treat, and appropriately refer the concussion patient of any age from acute to chronic stages. So why storytelling? Stories are powerful because they transport us into other people's worlds. By doing that, they change the way our brains work and potentially change our brain chemistry, and that's what it means to be a social creature. We don't have the capacity for meaningful attention greater than 20 to 30 minutes. Listening to hours and hours of lectures, whether they be in person or online, in a formal university setting, in service in your clinic, or national conference, this manner of learning is often unproductive. Storytelling allows us to step back, view, and listen from an aerial and reflective standpoint while creating the neural groundwork of patient exposure by connecting to the story, the provider, the caregiver, and the patient. Schwartz rounds were invented by an ill physician who also experienced the profound dichotomy of being both doctor and patient. His purpose was to facilitate understanding of how the patient perceives their own illness and treatment by deploying empathy and building rapport. If we have no empirical data, then we need to learn from each other. I sincerely can't stress this enough. I believe by deeply listening to each other, patients, and caregivers fosters an excellent way to change the way in which we begin to shift the global architecture of medicine with respect to the concussion patient of today. So who is the post-professional concussion student? Essentially, it's anyone with direct access to patient care. Concussion patients have the ability to access anyone in the healthcare continuum at any given time. This is not an excuse to not initiate This is no excuse to not initiate excellent care by taking a comprehensive history at day one point of care. We have to do a better job globally for these patients, and I believe this program is a stepping stone to the answer. Admission requirements for the Evidence in Motion Concussion Management Certification are as follows. All healthcare providers must meet the minimum education and credentialing requirements for their respective career to be evaluated during the application process. If English is not your native language, specified language proficiency requirements must be met. All healthcare providers must possess a current and valid license to practice in their respective profession. This license must not be under suspension, revocation, probationary status, or subject to disciplinary proceedings or inquiry. Non-licensed rehab techs will be considered on a case-by-case basis. So, concussion is a confusing injury. I'll invite you to take a moment with me and sit your clinical ego down on the floor for just one moment. This is tough for us because our clinical confidence is such a part of what makes us a competent clinician, and that's a huge part of why patients trust you. But hear me out for a minute and take this humbling journey with me. We do not define concussion neurologically. We do not understand the natural history of concussion. We have little, if any, data on neurobiological recovery following a concussion, and the medical and neurological community enabled a culture that did not address concussion. There are over 43 working definitions of concussion, and only one of them is evidence-based. Concussion is sincerely an all-hands-on-deck injury. The injury of concussion presents clinicians with an incredible array of complex and often complicated symptoms when they live on their own. Folks who are living with concussion tend to have more than 3 and sometimes the upper echelon of 10 or more symptoms at any one given time. We can't just address the headache or the ocular motor issues or the dizziness. This is an all-hands-on-deck injury. These patients often arrive into a state of frazzle, which is opposite of flow. Neurobiologists call frazzle a constant stress overload on their nervous system, which floods of cortisol and adrenaline that can override the system. Attention then fixates on their worries, not on their jobs, their families, the activities of daily living, and so on. These persistent and chronic patients often look like a chronic pain patient, and this adds another layer of complexity on top of this multifactorial injury presentation. Kenneth Burke is an American literary theorist, and this is one of my favorite quotes from him. Seeing is a way of unseeing. If we're solely looking for the headache or the cervical spine injury or the ocular motor issues that we have spent years and countless hours honing in on our craft, we sincerely cannot treat this cohort of patient with a do no harm mentality in mind. I'll be thoroughly reviewing the Dunning-Kruger effect during the course curricula throughout the year. And I challenge you, we're going to have to think beyond our specialty area to care for these patients well. Concussion 101. Concussion is an injury that requires an incredible amount of breadth and depth of comprehension across numerous systems in the body. Most healthcare providers and civilians on a global basis do not understand the multifocal and multi-system nature of this injury. They have inaccurate beliefs about recovery time, have a lack of awareness of the diversity of problems concussion can cause, have numerous misconceptions about the capabilities of brain injury survivors depending on the visibility, and this word is very important, the invisibility of their disability, and often misidentified brain injured individuals as mentally ill or learning disabled. Concussion is an injury that skews patients' perceptions of themselves, their environment, and their emotions. We need a more unified approach to managing concussion and traumatic brain injury. I believe the Evidence in Motion Concussion Management Certification is an excellent step to get us there on a global perspective. There are up to 3.8 million traumatic brain injuries occurring in the United States every year. Many of them are sports and recreation related, and there are over 800,000 Americans that seek outpatient care for this injury each year. I say this time and time again. It's not a matter of if you treat concussion patients, it's a matter of when you will either encounter, treat, or refer one, if not many, in your career. In 1997, the CDC reported that there were 300,000 TBIs in the United States then. Today, in 2016, the CDC, the upper echelon, reports that there are 3.8 million traumatic brain injuries per year. If we look conservatively at this number, we're doing a much better job about identifying this injury than we were 10 years ago, although it's often still mis- or under-identified. However, I think we still have a long way to go, and these numbers are still significantly skewed and underreported even to this day. Consistent ranges in the literature estimate about 20 to 30% of concussive injuries transition over to chronic and persistent symptom sufferers. Conservatively, if the upper echelon of the 2016 CDC data of 3.8 million traumatic brain injuries happening per year, we're looking at up to and potentially over 1.14 million people in the United States suffering from the persistent symptoms of concussion or post-concussive syndrome. Despite sport concussions getting the most attention and funding, the leading cause of concussion and TBI are falls, followed closely by motor vehicle accidents and domestic violence. Of all traumatic brain injuries, mild traumatic brain injury or concussion are the most common, and numbers from the Department of Defense TBI numbers worldwide range from 84 to 97% of traumatic brain injuries are actually concussion. The NIH reports research funding every year. So in this slide, we're comparing cancer funding to traumatic brain injury funding. Traumatic brain injury for this year alone will receive $91 million for traumatic brain injury research. This year alone for cancer, we're looking at $5.6 billion. So why compare cancer and TBI? Because cancer has made huge gains by breaking down cancer. I'm going to say this again. This is so important. Cancer has made huge gains by breaking down cancer. We don't simply treat cancer. We treat large cell non-Hodgkin lymphoma. We need to do the same in the concussion community to start breaking down this injury in a more precise fashion. However, for the patient and clinician of today, we're still not there yet. For research purposes, we need to start thinking where the concussive and axonal injuries are occurring and tailoring specific treatments to those patients. However, once again, we're still not there yet. Concussion 101. I make this really clear when I lecture publicly and I teach, and even educating patients to this day. There is no drug, no image, and no single tool or test that can diagnose a concussion. Tools only gather information, and it's really important to focus on that there is no test out there that outperforms a well-trained clinician. And concussion is a clinical diagnosis only. So I really hone in on that key component there, is that there is no test out there that outperforms a well-trained clinician. No matter what area of specialty you're practicing in, from emergency medicine to physical therapy, if you're a pediatrician, family practitioner, occupational therapist, athletic trainer, and so on, there are four questions that every patient wants to know. What is wrong with me? How long will it take? What can I, the patient, do for it? And what can you, the healthcare provider, do for it? On a global scale, we are not meeting the needs of concussion patients, acute to chronically, especially focusing on those 20 to 30% of persistent symptoms patients and post-concussive syndrome patients. We have to do better. So we've covered the what. Let's focus on a few of the whys. So why the need for this type of program? Well, we know that concussion is an all-hands-on-deck injury, and we're no longer in a day and age where the one physician or one clinician model can confidently and competently take care of the patient of today, and this is particularly profound when it comes to the concussion patient. I had the privilege to sit in on the 2014 International Conference on Residency Education. The opening plenary was delivered by Dr. Lorelei Lingard. And two key concepts I took from her lecture were as follows. 1, individual competence does not equal good health care. 2, our patients are experiencing a maze of disconnected care episodes, so we're often not communicating very well with each other, either interdisciplinary or cross-disciplinary, and with an injury that is as pervasive as concussion. This is clearly unacceptable. We have to do better. We can and we will. So who is part of the concussion team? We have this incredible list of highly skilled and very well-trained clinicians. However, are we communicating with each other as well as we can be? And do we really understand the scope of each other's practice and what we can do for our mutual concussion patients together? So we can implement our best care and provide the appropriate temporal referral when needed. These are just to name a few. Concussion signs and symptoms. We have this vast array of concussion signs and symptoms, and they cross multiple specialty areas and multiple domains of the human frame and psyche, and no one clinician can comprehensively care for all of these signs and symptoms that make up a concussive injury. Evidence in Motion concussion certification hopes to facilitate collective competence across the healthcare continuum in order to better triage, treat, and appropriately refer the concussion patient of any age from acute to chronic stages. So the focus here is to empower you, the student, the post-professional student, to become more comfortable with the concussion patient directly in front of you by giving you the tools to help do something and take interventional action steps and refer out appropriately as needed after you've taken an exquisite comprehensive history. I'm tremendously proud of what our faculty has put together for each and every one of you. So where did the inspiration and why the inspiration for this program? I was in a car accident in 2013 for what I believe to be a benign fender bender, despite the fact that I was immediately dizzy and almost fell over when I got out of my car and went to the emergency department via ambulance. When I got to the ED, I was diagnosed with a concussion, and my assumption was that I will take about a week to heal and keep moving on with my life, as I've done in the past as a student athlete and a woman who aided in running 4 concussion clinics as a junior partner of my company. Well, that clearly didn't happen, and I had persistent symptoms that just wouldn't go away, and I knew I had to seek out medical care. I sought out an orthopedist who looked at me sideways and sincerely asked me why I was in his office and referred me to a neurologist down the street the same day. I immediately knew I was being mismanaged when I was prescribed 5 PO medications to help me get through my day after an acute brain injury. This led me to seek out appropriate care focusing on an interdisciplinary team approach. Well, I struggled. And I struggled for over 10 hours of rehabilitative therapy a week for over a year to get my life back in order. A concussive injury presents a patient and a clinician with a remarkable dilemma. As clinicians, we often don't have the objective measures to quantify the variation of symptoms this pathophysiological injury creates. And the patient is often unable to subjectively describe what they are feeling or experiencing. A concussive injury is an injury of feeling less than and disconnected to our own self. Getting lost in conversation, sometimes mid-sentence, and being fully cognizant of what is happening is incredibly frustrating to oneself and the person you're trying to communicate with. To the patient, this often becomes an embarrassing feeling, fostering feelings that can often lead to seclusion and loneliness, which is a very common theme for TBI survivors. So I challenged myself, how can I help the medical community? When we think about empirical research, it unfortunately tends to come from a top-down approach. However, true evidence-based medicine, based off the original article in 1996 by Sackett and Guyot, reviewed the 3-pillar approach: peer-reviewed literature, the clinical expertise, and the patient values. However, as I had to step away from my clinical self during the tough realization that there is sincerely no true evidence-based medicine for concussion, I realized how important the patient experience was and sharing the patient experience story with the clinician, hence the storytell for this program. So yes, when we know that concussion is confusing, but isn't an entry-level medical education good enough? To put it simply, the answer is no. And Dr. Hainline, the chief medical officer of the NCAA, said it really wonderfully that the medical community has enabled a culture that has not addressed concussion. We really missed the boat here, people. So 2015 was the first academic year in which there is formal training for TBI and concussion as part of the neurology residency. It is taking place within behavioral neurology, and this springs from the work and advocacy of the sports neurology section of the American Academy of Neurology. Now, this is wonderful work. However, we are way beyond fashionably late to this so-called concussion party, and we've unfortunately allowed the medical legal literature and the unfortunate culture of "I got my bell rung" to present clinicians and the lay public with some serious cognitive biases. Fact: concussions are brain injuries, period, end of story. A new article came out in February 2016, and it was published in the Physician and Sports Medicine Journal. And the title of the paper was, "Is Current Medical Education Adequately Preparing Future Physicians to Manage Concussion?" Now, this was an initial evaluation. However, I think the paper illustratively paints a picture that's perfect, and here were the results. The data suggests that the vast majority of medical students are able to define concussion, which is excellent. However, most reported never having a lecture dedicated to concussion during medical school, and also lacked clinical experience with acute concussion and post-concussive syndrome. There are clear areas of deficiency as noted by the inability of students to correctly identify symptoms and appropriately manage concussion. Conclusion: the study indicates that at individual Midwestern top 50 medical schools, current medical trainees may not be adequately educated to identify and manage concussion. This is why the post-professional education of clinicians is so very important, and this is why I brought this program to Evidence in Motion. And this really is across all areas of medical education. So during my recovery, I knew I needed to keep moving forward. And the unrelenting question that kept getting posed to me in my mind was, how is there nothing multidisciplinary and post-professional that fosters learning and treating together that is as comprehensive as what I had thought up in my mind? So I had this aha moment, and this wonderful opportunity came up in front of me in the early part of 2015. So why Evidence in Motion? Well, I needed a trusted space looking for a blended classroom model that fostered an interactive and dynamic asynchronous and synchronous learning environment, offering in-person teaching opportunities. And that's when I met John Childs, the CEO of Evidence in Motion. Now, Dr. Childs and I met for a business meeting in 2015 in Indiana at our national conference. And I knew Evidence in Motion was the right home for this project when I asked him over lunch, where did the EIM concept derive from? And he simply stated that after his PhD in 2003, out of the frustration of research being produced in an ivory tower and research taking 10 to 15 years to reach clinical practice, is how he started EIM. I knew this project had found the safe space I was looking for, especially with the company that is run by clinicians for clinicians, who are producing some of the top research and clinical prediction guidelines in musculoskeletal and orthopedic care internationally. EIM prides itself with genuine humility, which is one of their deeply held values, because to be a legitimate lifelong learner, you have to update your knowledge over time and always be willing to admit that your ideas may be ill-informed. What's great is that the faculty are as engaged in lifelong learning as their students, and together we learn together. Evidence in Motion has the ability to tap into an international audience of clinicians that has produced nothing but high yield and consistent residencies, fellowships, entry-level doctorates, certifications, continuing education courses, and most importantly, a loyal group of students whom have proven to be leaders in their field of medicine. This is evident with a 75% retention rate for students that have taken a course once and they take another course again. So my plan is to do it well, do it differently, and create a loyal group of motivated clinicians, researchers, and scientists. So we've covered the what and the whys. Let's move on to the how. The Evidence in Motion Concussion Management certification is a full-year curriculum. The majority of the program is didactic content is delivered via internet-based learning. So coursework, interactive chat discussions, streaming video and audio, and the easy-to-use, no training required Moodle is where the curriculum will live. This full-year curriculum is actually built up of over 36 weeks of total didactic education. The students themselves will have 52 weeks to complete. There'll be a four-week introductory course delivered by myself. In conjunction with that 4-week intro course, we'll be offering a therapeutic neuroscience education course for 6 weeks as well. And I'll get into that in a little bit. The synchronous learning environment is involved in the management course, and that's an 8-week course that we'll also review in the future. Specialization topics range from 12 to 16 weeks of specific asynchronous training, and the in-person weekend intensive will review the psychomotor properties of what it takes to be a comprehensive clinician with respect to concussion identification, treatment, and management. So we've covered the what, the why, and the how. Now let's cover the who. Who are the faculty? Well, I specifically sought out faculty that are extremely intelligent, offering up a rare combination platter of having high IQs, high emotional intelligence, and low egos, with a voracious passion for what they do in their respective fields, whether it be publishing empirical data in literature, providing high-yield blogs and podcasts, contributing to their national and international organizations, and just being overall leaders in their respective field. Essentially, I've put together a group of unicorns. So I'll be delivering the introductory 4-week course, and I'll be taking you through the introductory course, which will be complemented by Dr. Lowe's therapeutic neuroscience education course. Now, concussion is not a one-dimensional injury, and I will be taking you through some Concussion 101 bootcamp, breaking down myths and facts, investigating contributing factors to acute, subacute, and chronic symptoms, rest as a contributing factor to both help and potentially harm, the neurometabolic cascade to guide you in thinking of the neurophysiological happenings of when you are taking a comprehensive clinical history, how to approach this injury from a thoughtful, biopsychosocial, and rehabilitative team approach, provide you with the available tools needed to aid you in your clinical practice, and the list goes on. Chronic pain affects over 160 million Americans, about 1 in every 3.5 Europeans, and new data from last year says that every 1 in 4 Australians are living with chronic pain. Now, pain is rampant and also a key component I'll tie into with post-concussive syndrome. Dr. Lowe is about one of 15 chronic pain specialists in this world who does what he does as well as he does, not only in a literature publication, but in medical education. He will go into a 6-week introductory course on therapeutic neuroscience education, also known as TNE, and I will provide adjacent information reviewing how the post-concussive syndrome patient models many of the behaviors and characteristics of a chronic pain patient, and how we can absolutely help and approach these patients from a different lens you can hopefully incorporate in your clinical practice next day. Oftentimes, we can help non-pharmaceutically with empowerment, deep listening skills, and utilizing words that help versus utilizing words that harm. Now, the questions I've gotten posed is, well, why this course with a concussion education program? And I sincerely believe that if we're bringing in a multidisciplinary group of clinicians, we're all speaking the same language of medicine. However, we're bringing different dialects to the table. So this is going to be a wonderful way to get us talking on the same page. Now, the concussion management team will be taking you through the 8-week synchronous management course after the 10 weeks of the introduction and the therapeutic neuroscience education course. The 8-week curriculum looks a little bit like this. We have 1 week of emergency medicine, essentially how to keep patients out of the emergency department unless there's some serious yellow or red flags. Adult neurology, headache, post-traumatic headache, migraine, and pharmaceutical management. The cervical spine, musculoskeletal management, non-pharmaceutical headache management, and whiplash-associated disorder, which is often missed in many concussion evaluations. Week 4 will be the vestibular rehabilitation. Week 5 will be vision rehab. Week 7 will be neuropsychology. Week 8 will be speech-language pathology, and then I'll be delivering the executive summary in the final week as well, fostering that collective competence approach that we've been talking about this whole lecture. Now, I encourage you to learn more about your faculty members at the Evidence in Motion Concussion Management website, as these are the men and women who are producing the literature, shifting treatment paradigms, and changing the medical culture on how we approach, identify, and treat concussion patients from the NCAA, Department of Defense, emergency departments, and so on. Now, we'll have 4 specialty topic areas, and they include pediatrics, geriatrics, sport, and a combined domestic violence and service member topic area. Again, faculty are world-class, and they bring not only real-world perspectives to what's really happening in clinic today, but they bring an impressive breadth and depth of knowledge with them and from their clinical expertise that I sincerely believe to be unparalleled. To get to know and read more about our wonderful faculty, please click on the faculty document on the Evidence in Motion Concussion Management homepage. So we reviewed the what, the whys, the how, the who, and how about the when? Well, the when is essentially now, and we'll have rolling admission starting in March 2016, July 2016, September, and January, and then we'll be repeating those rolling admission dates as well from year to year. So we've covered the 5 key questions for the lecture. Now let's talk about the cost. The cost for the 12-month of curriculum, 1 weekend in-person intensive, are $5,450 American dollars. There's a $100 application fee, and prices include all coursework and learning materials. Now, if you have questions about groups of 3 or more, whole clinics, or even hospital discounts, I know that Evidence in Motion does tailor and offer discounts for groups larger than 3. Payment schedule is $2,000 down payment due 30 days from the start of the first course. The remaining balance can be spread out over time and over the length of the program with a monthly payment. Now, the beauty of this program is that it's self-paced and paced for you, because we appreciate that you're practicing clinicians, raising families, maybe educating others yourself, and treating a full caseload. So with Evidence in Motion, this is sincerely, you get a lifetime of learning and connections, and that's really why I brought this program to EIM. So many questions that people ask about these certification programs are, what initials do I earn? And it's not unusual to see a wide array of alphabet soup behind our names. But this sincerely dilutes who we are, so we strongly urge physical therapists, physicians, nurse practitioners, athletic trainers, physician assistants, and so on, that have completed our certifications to exactly state what they are certified in and not use the initials behind their name. So I challenge you to be prideful in communicating that you went through a year-long intensive boot camp on concussion identification, treatment, and management, facilitating collective competence across the healthcare continuum. Use the education you've corralled over this next year and go empower your colleagues, your community, school districts, and patients with the knowledge that you've accumulated, and be that difference in your specialty niche. I leave you with a quote from Maya Angelou that inspires me every day to be a better clinician. I did then what I knew how to do. Now that I know better, I do better. Thank you so much for your time and attention, and if you have any questions, please feel free to call or email at the links below. Be happy to answer anything that you may have. Have a good day.